Epiglottitis is a medical emergency that requires immediate recognition and management. Epiglottitis is defined as acute inflammation in the supraglottic region of the oropharynx, with inflammation of the epiglottis. The epiglottis is a leaf-shaped cartilage structure that covers the opening of the larynx during swallowing, preventing food and liquid from entering the airway. The supraglottic region refers to structures above the vocal cords, including the epiglottis, aryepiglottic folds, and false vocal cords. The image shows a severely swollen, cherry-red epiglottis that's almost completely obstructing the airway. This dramatic swelling can develop rapidly, within hours, and can lead to complete airway obstruction and death if not promptly treated. Regarding causative agents, the most common bacterial cause is Haemophilus influenzae, specifically type B, accounting for about 25% of cases. However, the incidence of Haemophilus influenzae type B epiglottis has dramatically decreased since the introduction of the HIV conjugate vaccine in the 1980s. This represents one of the great success stories of vaccination. Following Haemophilus influenzae, other causes include Haemophilus parainfluenzae, Streptococcus pneumoniae, and group A streptococci. Viral causes of epiglottitis are rare and generally less severe than bacterial causes. The typical patient with epiglottitis presents with severe sore throat, difficulty swallowing, drooling, because they cannot swallow their saliva, high fever, and respiratory distress. A classic sign is the tripod position, where the patient sits leaning forward with hands on knees and chin thrust forward to maximize airway opening. The voice may be muffled, described as a hot potato voice. Epiglottitis is a true emergency, because the airway can become completely obstructed at any moment. Understanding the pathogenesis of epiglottitis helps us appreciate why it develops so rapidly and why it's so dangerous. Often, a viral upper respiratory infection may precede bacterial epiglottitis. The viral infection damages the respiratory epithelium and impairs local immune defenses, setting the stage for bacterial invasion. When Haemophilus influenzae type B infection starts, the progression is rapid and dramatic. There's rapidly progressive erythema and swelling of the epiglottis occurring within hours, and can progress to complete airway obstruction. Importantly, bacteremia is usually present. A key virulence factor of Haemophilus influenzae is that it produces IgA protease, an enzyme that degrades secretory IgA. By destroying IgA, the bacteria can more easily attach and colonize the respiratory mucosa. The inflammation and edema develop in the epiglottis and other soft tissues above the vocal cords in the supraglottic area. As these tissues swell, several problems develop. Phonation, or voice production, becomes difficult, leading to muffled phonation or complete aphonia, which means loss of voice. The swelling causes severe pain, which, combined with the mechanical obstruction, leads to dysphagia. Patients drool because they cannot swallow their saliva. Most critically, the progressive swelling narrows the airway. The epiglottis can swell to several times its normal size, and combined with swelling of surrounding tissues, this can lead to complete airway obstruction. This is why epiglottitis is considered a medical emergency, requiring immediate intervention. Laryngitis is inflammation of the larynx and manifests in both acute and chronic forms. It is particularly common in children. Acute laryngitis is what we'll focus on, as it's most relevant to infectious causes. Viral infections of the URT commonly spread downward to involve the larynx and trachea. This downward progression follows the concept of the respiratory tract continuum we discussed earlier. The most common causative agents are viruses, particularly parainfluenza virus, which accounts for about 75% of cases, respiratory syncytial virus, or RSV, influenza virus, and adenovirus. Bacterial causes are rare in otherwise healthy individuals. An important anatomical consideration is that the larynx and trachea have non-expandable rings of cartilage in their walls. While this structural support keeps the airway open under normal circumstances, it becomes a problem during inflammation. When the mucosa swells due to inflammation, the airway cannot expand outward because of the rigid cartilage rings. Therefore, the swelling narrows the airway lumen internally. This is especially problematic in young children because of their narrowness. A small amount of swelling that would be insignificant in an adult can cause serious airway obstruction in a young child. This explains why laryngitis and croup are much more serious in children under 3 years of age. In laryngitis, inflammation is primarily localized to the subglottic laryngeal structures, including the vocal cords. This inflammation of the vocal cords causes the characteristic hoarseness or loss of voice that defines laryngitis. Patients may also have a harsh, barking cough. Sometimes, laryngitis extends beyond the larynx to involve other parts of the respiratory tract. When it extends to the trachea, we call it laryngotracheitis, commonly known as croup. When it extends further to the bronchi, we call it laryngotracheobronchitis. Croup is characterized by a deeper, more severe cough than simple laryngitis. The cough is often described as a barking or seal-like cough, which is quite distinctive. This severe coughing may provoke chest pain from the forceful coughing and muscle strain. The pathophysiology involves inflammation and edema of the epithelium, mucosa, and submucosa of the subglottis. The subglottis is the area immediately below the vocal cords, which is the narrowest part of the pediatric airway. Swelling in this area can lead to significant airway obstruction that typically worsens at night. Transmission of the viral pathogens occurs through two main routes. First, direct inhalation from a cough or sneeze, where respiratory droplets are expelled into the air and inhaled by others. Second, by contamination of hands from contact with fomites. Management of croup is mainly supportive, including humidified air, hydration, and in more severe cases, corticosteroids to reduce airway inflammation and nebulized epinephrine for acute airway obstruction. Most cases resolve without complications, but severe cases may require hospitalization for airway management. Since Haemophilus influenzae is an important cause of several URT infections, including epiglottitis, sinusitis, and otitis media, let's understand how we identify this organism in the laboratory. Haemophilus influenzae has unique nutritional requirements that are key to its identification. It requires two specific growth factors called X factor and V factor to grow. This requirement for both factors forms the basis for two important identification tests. The first test is called satellitism. In this test, Haemophilus influenzae is streaked on blood agar, which contains X factor but not V factor in an available form. Then, a strain of Staphylococcus aureus is streaked across the plate. As Staphylococcus aureus grows, it lyses the red blood cells and releases V factor into the surrounding medium. Haemophilus influenzae can then grow only around the Staphylococcus colonies, where V factor is available, creating a satellite pattern, hence the name satellitism. The second test uses paper discs or strips impregnated with X and V factors. These are placed on an agar plate, inoculated with the test organism. Haemophilus influenzae will grow only around the disc containing both X and V factors, or in the area where separate X and V factor discs are close together. If growth occurs only around X or only around V, it's not Haemophilus influenzae but another organism, with different requirements. These growth factor requirement tests definitively identify Haemophilus species, and are still used in many laboratories as a simple, reliable identification method. Laboratory diagnosis of epiglottitis requires special considerations due to the nature of this emergency condition. The specimen of choice is blood. Why blood? Because bacteremia is common in epiglottitis, and blood culture is often positive. Critically important, specimens should not be collected from the posterior pharynx in patients with suspected epiglottitis. Why this prohibition? Because any manipulation of the throat, including trying to take a throat culture or even examining the throat with a tongue depressor, can stimulate coughing or laryngospasm and precipitate complete airway obstruction. This could be fatal. Therefore, throat examination and culture are contraindicated in suspected epiglottitis until the airway is secured. For direct microscopy, gram stain of blood culture or other specimens reveals gram-negative pleomorphic coccobacilli. Pleomorphic means the bacteria vary in shape, appearing as short rods, coccobacilli, or even coccoid forms. This variable morphology is characteristic of Haemophilus influenzae. For culture, chocolate agar is the medium of choice. The colonies are smooth and gray. Serologic methods include latex agglutination tests, which can rapidly detect Haemophilus influenzae type B capsular polysaccharide antigen in blood, CSF, or urine. This provides rapid presumptive diagnosis. Molecular methods, particularly PCR, are increasingly used to identify Haemophilus in clinical specimens. PCR is rapid, highly sensitive, and can identify the organism even in patients who have already received antibiotics, where culture might be negative. Serious infections caused by Haemophilus influenzae, including epiglottitis, are treated with broad-spectrum cephalosporins. Third-generation cephalosporins like ceftriaxone or cefotaxime are preferred because they provide excellent coverage and penetrate well into tissues. These are given intravenously in hospital settings. Treatment also requires airway management, which is the priority. In severe cases, intubation or even emergency tracheostomy may be necessary to maintain the airway. The most important aspect of epiglottitis management is prevention. The Haemophilus influenzae type B vaccine, commonly called Hib vaccine, has dramatically reduced the frequency of epiglottitis and other serious Haemophilus influenzae type B infections. The Hib vaccine is a conjugate vaccine, where the polysaccharide capsule of the bacteria is chemically linked to a protein carrier. This conjugation allows even young infants to develop strong immunity. The vaccine is typically given as a series starting at 2 months of age. Since the introduction of routine Hib vaccination in the 1980s and 1990s, the incidence of Haemophilus influenzae type B epiglottitis has decreased by more than 95%. This represents one of the major success stories of modern vaccination programs. In countries with high vaccination coverage, epiglottitis in children has become rare, and when it does occur, it's more often caused by other organisms. Sinusitis is inflammation of the paranasal sinuses, which are air-filled spaces in the bones around the nose. There are 4 pairs of sinuses: the ethmoid, frontal, maxillary, and sphenoid sinuses. All communicate with the nasal cavity through small openings called ostia. The pathogenesis of sinus infection involves several factors, most of which act by producing obstruction or edema of the sinus opening, impeding normal drainage. Under normal conditions, the sinuses drain continuously through the ostia into the nasal cavity. This drainage is essential for sinus health. When drainage is impeded, several consequences follow. Mucus accumulates in the sinus cavity, providing a medium for bacterial growth. Oxygen in the trapped air is gradually absorbed, creating an environment favorable for bacterial multiplication. The stagnant secretions become infected, and consequently, bacterial infection and inflammation of the mucosal lining tissues develop. Predisposing factors for sinusitis can be divided into local and systemic factors. Local factors include upper respiratory infections, particularly viral infections that produce edema of the tissues around the ostia, narrowing or blocking the sinus openings. Mucosal polyps, which are benign growths of inflamed mucosa, can physically block the ostia. Deviation of the nasal septum can obstruct sinus drainage on the affected side. Enlarged adenoids, particularly in children, can block sinus drainage. Systemic factors include allergies, which cause chronic mucosal inflammation and increased mucus production. Immunodeficiency makes patients more susceptible to both the initial viral infection and the subsequent bacterial infection. Other systemic conditions affecting mucus production or ciliary function can also predispose to sinusitis. Streptococcus pneumoniae is the most common bacterial cause of acute bacterial sinusitis, accounting for about 30 to 40% of cases. This is the same organism that causes pneumonia, meningitis, and otitis media. It's a gram-positive diplococcus with a polysaccharide capsule. Haemophilus influenzae accounts for about 20 to 30% of cases. Non-typable strains, which lack the capsule, are actually more common causes of sinusitis than the type B strain we discussed with epiglottitis. Moraxella catarrhalis is increasingly recognized as an important cause, especially in children, accounting for about 10 to 20% of cases. This organism is notable because it often produces beta-lactamase, making it resistant to amoxicillin. Staphylococcus aureus can cause sinusitis, particularly chronic sinusitis, or sinusitis complicating trauma or surgery. In some cases, methicillin-resistant Staphylococcus aureus or MRSA may be involved, especially in healthcare-associated infections. Streptococcus pyogenes, the same organism causing strep throat, occasionally causes sinusitis. It's important to understand that most cases of acute sinusitis begin as viral infections. Viruses like rhinovirus, influenza virus, and parainfluenza virus cause the initial mucosal inflammation and obstruction. Only about 0.5 to 2% of viral sinusitis cases develop secondary bacterial infection. However, when bacterial infection does occur, these are the organisms typically responsible. This understanding helps explain why most cases of acute sinusitis resolve without antibiotics, as they're viral, while cases with persistent or severe symptoms may benefit from antibiotic therapy directed against these common bacterial pathogens. Here's a step-by-step pathogenesis of how sinusitis develops and progresses. The process typically begins with viral or bacterial infections that impair the ciliary activity of the epithelial lining of the sinuses. The sinuses are normally lined with ciliated pseudostratified columnar epithelium. When viruses or bacteria infect these cells, ciliary function is impaired, slowing or stopping mucus clearance. Simultaneously, infection triggers increased mucus secretions as part of the inflammatory response. The combination of increased mucus production and decreased ciliary clearance leads to mucus accumulation in the sinus cavity. This accumulated mucus causes obstruction of the paranasal sinus ostia, impeding drainage. Once the ostia are blocked, the situation worsens in a vicious cycle. With obstruction established, bacteria multiply in the sinus cavities. The stagnant mucus provides an excellent growth medium. Common bacteria from the nose and nasopharynx gain access and multiply in this protected environment. As bacteria multiply, the mucus is converted to mucopurulent exudates, meaning it becomes thick, yellow or green pus, containing numerous white blood cells, dead bacteria, and cellular debris. This pus further irritates the mucosal lining, causing more edema and swelling. The swelling further obstructs the ostia, creating a self-perpetuating cycle. The inflammation also causes epithelial destruction, damaging the ciliated cells and reducing the sinus's ability to clear secretions even further. If acute sinusitis is not resolved, either through natural drainage or with treatment, it becomes chronic sinusitis. In chronic sinusitis, mucosal thickening results from prolonged inflammation, causing permanent changes in the sinus lining. The development of mucoceles, which are cyst-like accumulations of mucus, and polyps, which are inflammatory growths, may ensue. These structural changes can cause persistent symptoms and may require surgical intervention. Symptomatic treatment is important for patient comfort and to promote drainage. Analgesics such as acetaminophen or ibuprofen help with the pain and discomfort over the affected sinus. For antimicrobial therapy, A beta-lactamase-resistant antibiotic is preferred because many of the common causative organisms produce beta-lactamase. Amoxicillin clavulanate is commonly used as first-line therapy. The clavulanate component inhibits beta-lactamase, allowing the amoxicillin to be effective even against beta-lactamase-producing strains. Alternatively, a cephalosporin such as cefuroxime or cefpodoxime can be used, especially in patients allergic to penicillin. For patients with severe penicillin allergy, respiratory fluoroquinolones like levofloxacin or moxifloxacin are options, though these are typically reserved for adults due to potential side effects in children. Prevention strategies are important to reduce recurrence. Proper care of infectious and allergic rhinitis helps prevent progression to sinusitis. This includes using antihistamines for allergies and treating viral upper respiratory infections supportively to minimize mucosal inflammation. Surgical correction may be necessary to relieve or avoid obstruction of the sinus ostia. Functional endoscopic sinus surgery can enlarge the ostia, remove polyps, or correct anatomical abnormalities like deviated septum. Root abscesses of the upper teeth should receive proper dental care to avoid secondary infection of the maxillary sinuses. The roots of the upper premolars and molars extend close to or into the floor of the maxillary sinus, and dental infections can directly spread to the sinus. Unfortunately, there are no specific preventative measures like vaccines for sinusitis, as it's caused by multiple different organisms and often follows viral infections. Otitis media is inflammation of the middle ear space and eardrum, and it's one of the most common infections in childhood. The middle ear is an air-filled space behind the eardrum that contains the tiny bones of hearing, the malleus, incus, and stapes. This space normally communicates with the nasopharynx through the eustachian tube, which allows pressure equalization and drainage. Otitis media affects 85% of children before the age of 3 years, making it one of the most common reasons for pediatric healthcare visits and antibiotic prescriptions. Why is it so common in children? Children's eustachian tubes are shorter, more horizontal, and more easily obstructed than adults, predisposing them to middle ear infections. Regarding causative agents, bacteria are the primary causes. Streptococcus pneumoniae is the most common cause overall. Importantly, specific serotypes have been identified as most frequently causing disease in children. Haemophilus influenzae, particularly non-typable strains, is the second most common cause. Moraxella catarrhalis has emerged as an increasingly important cause, particularly in children with recurrent otitis media. It's notable for frequently producing beta-lactamase, making it resistant to amoxicillin. Staphylococcus aureus can also cause otitis media, though less commonly. Among viral causes, parainfluenza virus is the most common, though virus is more often predisposed to bacterial otitis media rather than causing primary viral infection of the middle ear. The photograph shows acute otitis media with a bulging eardrum, which appears red and pushed outward by the pus accumulating in the middle ear space. Understanding the pathogenesis of otitis media helps explain why it's so common in children and how to prevent recurrences. The key issue is disturbances in eustachian tube ventilation. The eustachian tube normally performs several functions. It ventilates the middle ear, allowing air to enter and maintain atmospheric pressure. It drains secretions from the middle ear into the nasopharynx, and it protects the middle ear from nasopharyngeal secretions and pathogens. When eustachian tube function is impaired, problems begin. Common causes of impairment include upper respiratory infections causing mucosal swelling, adenoid hypertrophy blocking the tube opening, allergic inflammation, or anatomical factors in young children. As ventilation is lost, oxygen is absorbed from the air in the middle ear cavity. The middle ear is highly vascular, and oxygen diffuses from the middle ear airspace into the blood vessels in the surrounding tissue. This creates negative pressure in the middle ear, like a partial vacuum. This negative pressure, in turn, allows entry of potentially pathogenic bacteria from the nasopharynx into the middle ear. The nasopharynx normally harbors bacteria like Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. When negative pressure develops, these bacteria can be drawn up through the eustachian tube into the middle ear. Failure to clear these bacteria normally results in colonization and infection. In a healthy middle ear with good eustachian tube function, bacteria that enter are quickly cleared. But when ventilation is impaired and secretions accumulate, bacteria multiply, leading to acute otitis media. Clinical presentation can be subtle, especially in young children. Acute otitis media should be considered in any child with unexplained fever, diarrhea, or vomiting, even without specific ear complaints. Older children may complain of ear pain, but infants may only show nonspecific signs like irritability, poor feeding, or pulling at their ears. The image shows acute otitis media with a bulging eardrum, pushed outward by accumulated pus and inflammatory fluid in the middle ear space. Laboratory diagnosis of otitis media is not always performed, as diagnosis is often clinical based on otoscopy. However, in complicated or recurrent cases, microbiological diagnosis can guide treatment. Specimens that can be collected include ear discharge if the eardrum has ruptured and is draining, or tympanic aspirate obtained through tympanocentesis. Tympanocentesis involves puncture of the tympanic membrane with a small needle to aspirate fluid directly from the middle ear. This is the most reliable way to obtain a specimen, as it directly samples middle ear fluid without contamination from the ear canal. However, it's invasive and typically reserved for complicated cases, treatment failures, or immunocompromised patients. For gram stain, finding gram-positive lancet-shaped diplococci in association with leukocytes is important and suggestive of Streptococcus pneumoniae. The image shows these characteristic organisms. Finding these organisms amid white blood cells confirms that they're causing infection, rather than just being contaminants. The image also shows degenerating nuclei of polymorphonuclear cells, which are the larger, irregular red shapes indicated by the arrow. These are white blood cells that have died fighting the infection, their nuclei breaking down, which is typical in purulent infections. For culture, Streptococcus pneumoniae grows well on blood agar. The image shows Streptococcus pneumoniae colonies surrounded by a green zone of alpha hemolysis, which is incomplete hemolysis of the red blood cells in the agar. This green discoloration is characteristic and helps identify the organism. An additional identification test shown is optokin susceptibility. Streptococcus pneumoniae is susceptible to optokin, while other alpha-hemolytic streptococci are resistant. These laboratory findings, combined with clinical presentation, confirm the diagnosis and identify the causative organism, allowing for appropriate targeted therapy.